Welcome to Cancer Beat, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We will also examine proactive approaches to cancer prevention, and most importantly, how we are breaking barriers to beat cancer in our community and beyond. Dr. Marcio Malogolowkin is Chief of Pediatric Hematology and Oncology. Thanks for joining us, Dr. M, as we like to call you around here. It's great to have you.
Thank you very much, Chris and Stephanie. It's a pleasure being here today and sharing some of my ideas, answering questions, and exploring these important topics.
Wonderful. Our topic today is oncofertility. This is fertility preservation for those with cancer. And Dr. M, tell us, how does this work? You have, let's say, a young cancer patient, someone of childbearing age who comes in. How do you approach this rather sensitive topic?
Well, let me start by saying something, Stephanie. I think that having the right to have a child whenever you decide to have is preserving that right is an obligation that me as a physician, as a caregiver, have very much in mind and in my heart. Unfortunately, a lot of the advancements in cancer fight is associated with risks of infertility. And I believe that that needs to be very clear up front, and that we need to do everything that we can to make our patients aware, our families aware, and then explore the many available alternatives. So for me, fertility preservation in patients fighting cancer is not an option, is our obligation to discuss.
And perhaps it's not top of mind for them. It's something that the doctor has to bring up, right? Because they're so focused on just, beating their cancer. Is it something that you proactively bring up? Does this apply to both male and female patients?
So the first thing is that you're absolutely right. There is nothing more overwhelming than being told that you have cancer. The risks associated with treatment, the risk of losing your life, and all the troubles that you're going to go through during cancer treatment. So it's not unusual that our patients, no matter what age, if it is the pediatrics, the parents, and the adult ones, don't think about it. They're too overwhelmed to think about their future. And even some of the patients that already have kids don't think about the option of having further kids. So I think, as you mentioned, it's our obligation to remind them of that. At times, you're going to find that they don't want to deal with it at all because that's, I'm too young. I don't know about it. I don't care about it. But again, I think as a care provider, as a physician taking care of children, adolescent, young adults with cancer, is my obligation, our obligation, to make clear that they understand the risks, they understand the options. And the risks are not equal. Different ages, different sexes, different therapies, impact significantly on the risks of infertility. And the options are also very different. So as you asked, it applies for both males and females, but the risks are not uniform for everybody, for every disease, for every therapy.
Well, and you brought up a couple of great points there. First off, that there's a wide age range. So can you tell us kind of what that age range might be that you look at? And then also just tell us some of the different preservation options that exist for both sexes.
Sure. So the reality is that, especially for males, the age is whatever. You know that Picasso, the famous artist, had a child, I think, at 90 years of age. So who knows when you decide to have a child. Obviously, for females, this is a little bit more difficult because unfortunately, menopause, or fortunately, depending who you ask, menopause happens, and the ability to have child at that time is gone. But that doesn't mean that you may not decide at 40, 45 that you want to have a child.
Mhm.
So, there are different ways to approach. For males overall, especially if they are past puberty, is much easier because not all, but what you have to do is collect some sperm, evaluate that they're fine, and then freeze aliquots that can be used in the future. For females are a little bit harder because they need to harvest eggs, and the process is a little bit more troublesome because requires some hormonal stimulation and some planning to do that, different than the male that theoretically can go to the lab, provide the specimen. Usually we ask at least 72 hours without previous ejaculation in order to have a richer sample. But for females, you need to do a much more important planning. There are future options, and I'll be glad to talk about that a little bit later.
Are there any risks with this hormone therapy that has to accompany, at least with the women, young women? Like if I'm a cancer patient and I'm concerned that there may be a cancer risk associated with taking hormones to produce more eggs, is that an issue that comes up?
It's not really to produce more eggs; it's just to ovulate upon the men, sort of speak. So the biggest risk for me is because this has to be planned. There has to be some administration of hormones and cycling the female patient on her cycle so we can collect eggs. It involves both the administration of hormones that have some side effects, usually transient side effects. So it's not like long lasting, but they are transient, just like females on their cycle, they can be more symptomatic pre-ovulation. So that is the first side effect, but this is a very transient side effect. But more important, and the biggest issue that we all face with females is because of the requirement of planning, also it involves some delay in the initiation of therapy, which may be okay for some diseases, for some malignancies, but not appropriate for all.
Right. So before radiation, before chemo, this is all has to be incorporated, which you can see is challenging and
Absolutely.
a lot for a young woman to go through. What about insurance? Does health insurance cover this?
Nowadays there is some mandates that it has to be covered, but that doesn't mean that insurances at time do not give our patients some headaches and some stumbling blocks to get this provided. We work very closely with a partner locally. The Northern California Fertility Medical Center is our partner here at UC Davis. There are many others throughout the state and the country, but this is our partner here at UC Davis. And we have a very strong relationship. We have a regular meetings, and they are very proactive in helping us and our patients to find alternatives. There are foundations that help support our patients, but there is a fee. There is a fee for the immediate process, for the collection, both of sperm as well as the eggs. But there is also a yearly fee for the storage of the specimen.
You had mentioned that the time difference, I guess, between the males and females, because there is a little bit more planning and just upfront time to get everything ready in order to harvest eggs from females. What happens though if somebody isn't able to preserve their fertility prior to treatment starting? Are there any options that exist after treatment or during treatment?
It becomes a little bit more risky because sometimes the effects of during treatment becomes very complicated because obviously a lot of these therapies can be teratogenic, meaning can cause changes to the fetus, changes that would impact the pregnancy. So usually we avoid the collection of both eggs and sperm during therapy, and that's usually a contraindication. But afterwards, once the chemotherapy, the surgery, radiation is done, they can have children of their own. Very often, it's very important to say that infertility is not the norm, but is a risk. And actually being a pediatric and adolescent cancer physician, I have to remind many of my young patients that just because you got chemotherapy or even because you had a testicle removed or an ovary removed, that doesn't mean you cannot get pregnant. You still need to be careful. And that's, believe me, over my almost 40 years of practice, I found a few surprises.
Well, what type of tests do people need to go through if they decide to preserve their fertility?
Well, I think, for the male, again, there is a lot of testing in terms of infectious diseases like hepatitis, HIV, and all that stuff. So this is part of the evaluation of the patient because obviously you want to make sure that the sperm and the egg that you harvest are as healthy as possible. For the males, once the sperm is donated, there are some processing of looking at the counts, how many sperm, how mobile they are, how normal they look, in order for be a very good collection because the sperm is not frozen all in a group. They are split in aliquots that can be used. So obviously the more sperm the male produce, the more aliquots he will have for the future. And sometimes we even encourage our patients to go a second time to collect. For females, again, there are some measurements that our colleagues in the fertility facility measure change in temperature and hormones and all that, trying to make sure that the cycle is synced and they can do the appropriate collection.
Have you met some of these babies, Dr. M, that have come after? I bet that's very special.
Well, I think anything that deals with survivorship of our patients is special, and especially seeing them move on with their life, leave cancer behind, and resume a normal, disease-free life. That doesn't mean completely free of complications because, as we know, survivors have a lot of long-term side effects. But seeing that they can move on and build their families, have their own progeny is a pleasure that very few people can have. And I'm a lucky person to be able to experience that.
Well, I know you are so passionate about helping this age group. And this is all part of our adolescent and young adult program. Tell us a little bit more about our AYA program, as we like to call it, and how, what is your vision for this program?
So before we go there is one other aspect that I want to talk about fertility that I think it's important. Nowadays, there are research and there is even some work being done on testicular biopsies and preservation of the very primitive precursor of sperm cells. There is way to biopsy the ovaries and collect egg cells. Obviously, that involves surgery, that involves some processing of these cells. Some of it is done as part of research. Some is already being offered, including by our colleagues at the Northern California Fertility Medical Center, but that requires plan. My hope is that no matter what, if it is by sperm production, if it is by egg ovulation and harvesting, or if it is by biopsy of testicles or ovaries, that no patient will be left behind in their abilities to preserve their fertility. So that's my goal, and that's what I'm working very hard with many colleagues here at UC Davis to be able to offer for males, females with cancer, and other diseases as well that are associated with risk for infertility in the future.
And it's important to note that if we have some older patients who are listening, that aren't within that adolescent area, that while they may not see you, we have other specialists who also are involved with fertility preservation within the cancer center. And so we don't want anybody to walk away from this and think, oh, well, I'm outside of 25, so this doesn't apply to me.
You're absolutely correct. And one of the things that we have done, because I believe that fertility preservation is one of the first steps for treatment of cancer. So actually, we have created some stopping rules as patients are being treated. So, for example, when a doctor is starting to write a chemotherapy plan, the first question they ask is this patient, on a fertility age? If it yes, have you discussed fertility issues, yes or no? And we felt that was the first thing we could do to remind the physicians to talk about fertility. When we don't do it, is not because we don't care, it's because there are too many other things sometimes in our mind, planning for surgery, planning for diagnosis, planning for treatment, and other very important psychosocial, financial issues, and that end up being in the back burner. So that's one of the things we've done. Also, what we've done is developed some information for patients, both pediatric, adolescent, young adults, and adults, so they can advocate for themselves. They can ask their physicians before they embark on the journey of treating their cancer, is there a risk for fertility? What are they? Is there anything that we can do to mitigate or to preserve their potential for having children in the future?
So important. Just key questions to ask as a patient. And then you could see where the proactive approach by the doctor is so important, because again, as a patient, you've got that tunnel vision regarding just getting past the cancer. I think it's fabulous that you've built in this sort of automatic question that will come up, before the treatment plan, really.
Absolutely. Thank you.
So what's your vision for the future in helping this age group?
Well, so adolescent young adults in this country is defined by the National Cancer Institute as anybody between 15 years of age and 39 years of age. It's a very wide range. And everybody asks me why AYA is this age. And that happens in this country. Most countries, AYA, the adolescent young adult patients are usually between 15, 12 to maybe 25, 27, 30. The rationale for that is because when many smarter people than me a few years ago look at the data and look at improvement of outcomes of all patients with cancer, they saw that children have had significant improvement of outcomes as a result of new treatment, diagnosis, etc. The older adults, older than 40 or so, they have also had a significant improvement, not as much as pediatrics, but they had a very significant improvement, a lot as a result of treatment itself, but a lot of as a result of improvement in the screening. So we know about mammography, we know about colonoscopies, etc. So screening, especially for adult cancers that are in general much harder to treat, screening has made a huge difference in improving the survival of these patients. When you look between 15 and 39, there is a big gap in the improvement. That doesn't mean the treatment has not improved and their outcomes have not improved, but just not at the same level as the two other groups, the younger patients and the much older patients. And then people like myself and other investigators start asking, why is that? What is the difference between the adolescent young adults, the pediatric and adults? And we have found so far that there are many, many different reasons for that. Some may be the disease itself, some may be biological of the patient, some may be psychosocial compliance, and focusing and developing a program for adolescent young adults, we can try to envelop them in as much of a care as possible to give them the resources to go through cancer and to survive the cancer and receive the best treatment that they can.
What are the common cancers that you're seeing in this age group?
So, the most common cancers would be the leukemias and the lymphomas, some brain tumors. You also starting to see, that's the time where you start seeing some testicular tumors. You start seeing some breast cancer, a lot of skin cancer. We are starting to see in the entire country an increase in colon cancer as well. So, we need to make sure that these patients are recognized early. That when they go to the emergency room, for example, that people do not dismiss their leg pain or their abdominal pain as dysfunction, is anxiety because they have a new job and all that. Not that everybody has to have cancer until proven otherwise, but we can't ignore if somebody is having repetitive complaints, we need to think that cancer exists and we need to give the appropriate support for them to have a right diagnosis, right staging, and appropriate treatment.
Well, and also with the AYA program and just some of the things that you provide, it's not only the treatment, but it's everything else that goes around that also, right? There is peer support. There's maybe the opportunity for counseling, or at least, talking with social workers, nutrition. All of these things come into play so that our AYA demographic feels connected and feels supported.
Absolutely. So, as I like to say, in pediatrics, we cocoon our patients, we baby them. Mm-hmm. When you are adult with cancer, you're much more on your own. Mm-hmm. But we hope that most adults are established, they have a safe job, they have a family, they have people to support them. But especially the younger adolescent, young adults, the 20s, mm-hmm. Those patients are still growing, they're still developing, there is still a lot happening with their life, and cancer is just a nuisance. They have other things to do with their lives. They shouldn't be having cancer. And the idea of our adolescent young adult program is not to treat them like little children, mm-hmm. but is to give them, surround them with the support that they need, no matter if they are treated by me or if they are treated by one of our adult colleagues for colon cancer. I don't treat colon cancer unless it's on the very, very rare children. But if they are a 25-year patient with colon cancer, although I see 25 years, they're going to go to the appropriate cancer oncologist. But our program is there to give them the support, as you said, the social worker, the dietitian, the financial counselor, the spiritual counselor, and education, et cetera, et cetera, et cetera. And I hope that the et cetera will continue to grow as more options of support also are developed in our institution. I think I just would like to say for whoever is listening is that, again, is your right to preserve fertility. Don't get upset if doctors and nurses, as they start caring for you, they don't bring this immediately to your attention, but it's your right and you should fight for it. So make sure that you ask. Make sure that you make the right decision, because I have to tell you, unfortunately, I have had encounters with patients that said, well, I wish I was told, or I wish I knew. And the reality is that many times they were told, and but because there was not really a whole support to encourage fertility and all that, that's end up being a little blip in the ocean of a big discussion of diagnosis, prognosis, therapy, side effect, and long-term outcome. So even when told, sometimes, it doesn't come in the radar of our patients, adolescent young adults as well as adults. So I want to make sure that our patients that are listening, our families that are listening, and maybe it's not the patient, but the family, that they help advocate for this right of our patients.
All right. Thanks, Dr. Malogolowkin, for all of your insight and for just joining us today. And we thank you for tuning in and listening. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.